Assalamu alaikum. Now I would like to discuss about different respiratory pathogens. Starts with this lung abscess. So this is a picture of lung abscess where you can see the air fluid level. Air fluid level. This is the CT scan of the lung abscess where you can easily see the air fluid level. And by definition, lung abscess is the localized collection of pus within the lung parenchyma. This is a simple definition, and lung abscess usually happens due to aspiration. If the person is altered, if he has altered consciousness, like if he is alcoholic. In alcohol there is altered consciousness. If the person is under general anesthesia, and there may be the person might have epilepsy, the person might have Parkinson's disease, and if he has some form of neurodegenerative disorder, or GERD also can cause lung abscess. And esophageal dysmotility can cause lung abscess too. And the common organism of lung abscess, this is another histological picture of the lung abscess. Okay, the common organism is bacteroids, Fusobacterium. What I am trying to say is that all the anaerobes actually causing this lung abscess, that bacteroids, Fusobacterium, Streptococcus, Staph aureus also can cause lung abscess. Staph aureus also can cause this lung abscess. This is another picture of the lung abscess. In here you can easily see the air fluid level. And in lung abscess, depending on the location of the patient position during aspiration, if the patient is upright position, then the aspirated substance should be in the right lower quadrant. But if the patient is recumbent or lying position, then the substance might have in the right middle lower quadrant and right upper quadrant, right middle quadrant and right upper quadrant, if the person is in the recumbent position. And as a treatment, you should give antibiotic, like you can give ceftriaxone, you can give clindamycin, because there is the presence of anaerobic organism, and you should give the clindamycin too. And you can do drainage, and sometimes you need surgery. Now, mesothelioma. This is the CT scan of the malignant mesothelioma, where you can see the pleural thickening, and this is pleural effusion. In mesothelioma, it may present with hemorrhagic pleural effusion. There may be hemorrhagic pleural effusion, and there is pleural thickening. Malignant mesothelioma is associated with asbestos. It is associated with asbestos, and in here, if you do histology, you may get these Samoma bodies. In here, there is pleural thickening. In this picture, you can easily interpret that there is thickening of the pleura, pleural thickening, and in mesothelioma there is calretinine is positive. There is presence of Samoma body, and it is associated with asbestos. And the final important word I want to say that it is in here, smoking is not a risk factor. Smoking is now ARDS, that means acute respiratory distress syndrome. In ARDS, this is the X-ray of the ARDS. Look, there is bilateral lung opacity. There is bilateral lung opacity in ARDS. In ARDS, what you have to remember for remembering the cause of the ARDS, you have to remember the past. That means this is the mnemonic. That means pneumonia. That means pancreatitis, pneumonia, pancreatitis. There is aspiration. There is sepsis, and there is trauma. This is the histology of the ARDS, where you can see the formation of the intraalveolar hyaline membrane. There is formation of this is the intraalveolar hyaline membrane, formation of the intraalveolar hyaline membrane formation. There is formation of intraalveolar hyaline membrane. If you want to diagnose ARDS, you have to remember this mnemonic ARDS. That means abnormal chest X-ray. Already I have made you see that there is abnormal chest X-ray. There is respiratory failure within 1 week of alveolar insult. Respiratory failure within 1 week of alveolar insult. There is decrease PaO2 or FiO2, decrease PaO2 or FiO2. The ratio less than 300. Hypoxemia due to increased intrapulmonary shunting and diffusion abnormality. And as for symptoms of respiratory failure are not due to heart failure or fluid overload. Symptoms of respiratory failure, there is respiratory failure but not due to heart failure or fluid overload. The complication includes there is impaired gaseous exchange, there is decreased lung compliance, impaired gaseous exchange, decreased lung compliance, and there is pulmonary hypertension. For as a treatment, you should give mechanical ventilation. And in mechanical ventilation, there you should decrease tidal volume and increase PEEP. you should decrease tidal volume and increase peak positive and expiratory pressure. You should decrease tidal volume and increase peak. And finally, if you think about the pathophysiology of the ARDS, in here there is alveolar insult, release of pro-inflammatory cytokines, there is release of pro-inflammatory cytokines, there is neutrophil activation, neutrophil recruitment, and activation, and there is release of toxic substance like reactive oxygen species like protease, reactive oxygen species, and there is capillary endothelial damage and vascular permeability. Capillary endothelial damage and vascular impermeability, and there is formation of intraalveolar hyaline membrane. There is formation of intraalveolar hyaline membrane. And in here there is non-cardiogenic pulmonary edema. So pulmonary capillary wedge pressure, normally it is 4 to 12. It should be normal. Pulmonary capillary wedge pressure should be normal. So in ARDS you have to remember the mnemonic ARDS, and you have to remember the past. Now I would like to talk about the pneumonia. This is a picture of, this is the chest X-ray of pneumonia. Probably it is the right-sided. This is the right-sided lobar pneumonia. How it is lobar pneumonia? Look, it only involves the upper portion of the lung, upper and kind of middle portion of the lung, but lower and lower portion of the lung is spared. That's why this is lobar pneumonia. Lobar pneumonia, actually it can involve a single lobe, it can involve the entire lobe too. And this is the histological picture of a lobar pneumonia. Look, this is black and this is if you compare these two pictures, you can easily identify that this is lobar pneumonia. Usually lobar pneumonia occurs by strep pneumoniae. Most commonly the organism is strep pneumoniae, and the other organisms are Legionella and Klebsiella. Next, this is the CT scan of the lobar pneumonia. In here, the right-sided lung, there is patchy distribution, involves more than one lobe. In here, involvement of middle and lower lobe. This is patchy distribution involving more than one lobe. So you can say it easily that it is bronchopneumonia. In bronchopneumonia, there is patchy distribution involving more than one lobe, and it usually happens by the organism called strep pneumoniae. And Staph aureus is another culprit of this bronchopneumonia, and other organism is Haemophilus influenzae and Klebsiella too. This is the histological picture of This is a histological picture of bronchopneumonia where you can see the acute inflammatory infiltrate from the bronchioles and adjacent alveoli. And the next one is interstitial or atypical pneumonia. This interstitial or atypical pneumonia shows bilateral. It shows bilateral multifocal opacity. It shows bilateral multifocal opacities, and it is also known as walking pneumonia. And the final one is cryptogenic organizing pneumonia. It is usually chronic inflammatory disease like rheumatoid arthritis, and drugs like amiodarone is the most important culprit. And in here there is negative sputum. And blood culture. Negative sputum and blood culture, and there is no response to antibiotic. It is previously known as bronchiolitis obliterans organizing pneumonia. Now, this is the natural history of the lobar pneumonia. This is congestion. Congestion usually happens 1 to 2 days of the pneumonia, and findings are red, purple, and partial consolidation. Red, purple, and partial consolidation of the parenchyma, and exudate mostly with bacteria. And this is red hepatization. Red hepatization usually happens 3 to 4 days of the pneumonia. This is red, brown, and in here there is exudate with fibrin, RBC, and WBC. This is gray hepatization, uniformly gray, and exudate usually WBC, lysed, RBC, and fibrin. And the last one is resolution. It usually happens 8+ days, and exudate digest components of exudate. And that's all about the lecture.